excited to have you come out. September is Suicide Awareness Month. Friday night, Sanilac County Community Mental Health had a big awareness walk and speaker, and that was a wonderful program. And tonight we have Kellie Phelps from Community Mental Health as our presenter. She is a trained question, persuade, refer trainer, as well as mental health first aid. So we're really lucky to have her with us tonight. And then in October, there'll be another program near and dear to my heart. Our dietitian and our physical therapist will be talking about portion control and diet and exercise. And then in November, we'll have our holiday treats cook-off. Always please register with Tanya. She keeps track of everything. And for October 16th, for Lunch and Learn from 12 to 1, I'll be the speaker on Medicare and Medicare Advantage plans, the ins and outs of them. Lunch is $5. Healthy lifestyle is free. Please just register with Tanya. And with no further ado, Kellie.
Hi, good evening everybody. Thank you for coming out tonight. I really appreciate it. As Louise said, Friday night was a really wonderful evening. We had about 100 participants show up at our Suicide Awareness Remembrance Walk. And our speaker, Anthony Grappito, really shared a powerful story of hope with everyone, and the ceremony was very meaningful. So if you're able to make it next year, we'll be starting to advertise early. I hope you can come. So Lee says I've got 45 minutes, so we're going to get started in this. QPR, Question, Persuade, Refer. It was developed by Dr. Paul Quinnett and Associates of the QPR Institute in the late 1990s. And today there are over 2 million QPR gatekeepers trained. This is an evidence-based program. So at the end of the program, I have some certificates with me. If you need one to apply for CEUs for your profession, it just may qualify for that, okay? So just let me know and we'll pass them out to you. But let's get started here. Okay, there we are. So QPR is a suicide prevention and awareness program. It teaches you how to talk to somebody who may be experiencing a suicide crisis. What it's not is a therapy or a self-help group. It's intended to help teach us how to offer hope to someone who may be feeling hopeless. QPR is, like I said, an evidence-based program, and I think before we get started, we need to go over some statistics. I'm kind of a numbers person. I like the data. I think the data tells a story. In your packets, there is a paper with the Michigan numbers on it. But as you can see, in 2017, there were over 47,000 deaths in the United States by suicide. And suicide has consistently raised in numbers over the last 30 years, but you can see we are over 10,000 more today than in 2009. Timing of USA suicides, so there's one every 11 minutes. That's 129 a day. Absolutely. When you kind of get down those numbers, it's quite telling, isn't it? Suicide's a leading cause of death. It's in the top 10. Unfortunately, the money spent on suicide research and prevention falls far below what the numbers suggest we should spend. So overall, it's the 10th leading cause of death. And you see homicide, it's well over twice as many people die by suicide than by homicide. And yet, how much do we hear about that in the news? And how much research is done in harm prevention in that area? The national ranking, Michigan falls 36th, so We're right around mid-range. We're a little above the average for the number of deaths per 100,000. As you can see, you might expect that Alaska would be at the top, but Montana surpasses it at 29.6 deaths per 100,000.
I would think Washington, D.C. would be closer to the top.
well, maybe. But no, that is really interesting. It's pretty low, isn't it? Yeah. Yeah. Estimated attempts, there's 1 death for every 25 attempts. After an attempt, you're much more likely to try again. So that translates into 1.2 million attempts annually. The estimates may actually be higher according to researchers. Not all hospitals, not all emergency rooms or doctor's offices record injuries as attempted suicide. They're not always reported by the families properly, et cetera, et cetera. And we don't have real consistent reporting mechanisms in place. Julie Carell did a study. She estimates that there about 11 people will have a devastating impact in their lives after the loss of a loved one to suicide. And when we talk about a devastating impact, we're talking about the onset of disability as a potential, lost days from work, the onset of a mental health issue for that person as well. 11 people. And estimates in little rural areas like ours actually are higher. The thought process is that because we are a closer knit community, maybe our families are from here 2 or 3 generations, mine, well, my husband's is, but not mine, that there's more close family members. So the impact is actually more extreme in rural areas than somewhere like Detroit or Flint. The numbers impacted by suicide that are exposed to suicide. So 47,000 people in America die each year. That's over 1 million people who suffer devastating effects of suicide. Honestly, I started to do the numbers for how many may have died by suicide since 9/11 versus how many survivors or those left behind. It was too exponential. I just couldn't do it. If you really think about it, that's a lot of new survivors. Okay, the ratio of 11 people experiencing devastation. So 11 people every 11 minutes, or 1,419 a day of people who will experience the devastating impact of a loss by suicide. Well, let's talk about some myths versus facts. Quite often we have some beliefs that we hold about suicide, that we've heard, and we like to kind of bust those. So the first one we have here is no one can stop a suicide, it's inevitable. Well, that is false. If a person in crisis gets help, they'll probably never be suicidal again. Confronting a person about suicide will make them angry and increase the risk of suicide. Some people think that if you talk about suicide with somebody who hasn't actually mentioned it, you're going to put it in their minds. But that's not true. Actually, if you talk to somebody about suicide that you are concerned about, you may ease their tension and make them realize that somebody cares. So it kind of lowers that tension that's been building up. Only experts can prevent suicide? No, every one of us can prevent suicide. Every one of us. Now, every one of us cannot treat a mental health issue. We cannot treat a person who has a substance use disorder, which may lead to a suicide crisis. What we can do is listen to that person, talk to that person, ask the right questions, and connect them with help. And that's what we're going to practice this evening. All right. Suicide. People keep their plans to themselves. What do you think about that? Anybody? No?
Well, they talk.
They talk. They do. Do they always say, well, I think I'm going to kill myself?
No.
No. No. Oftentimes, suicide communications prior to an attempt are kind of veiled. What are some of the things that you might hear from a person?
I have nothing to live for.
I have nothing to live for. Statements of despair.
No friends.
No friends.
Yeah.
So what's the point? Other statements that you may hear from someone contemplating suicide are, you know what, that won't be a problem next week anyway.
Yes. Yeah.
We won't have to worry about that much longer. So they can be kind of veiled, but there are indicators out there. Most people will give some sort of indication. Those who talk about suicide don't do it. Often we think of suicide as an attention-seeking behavior, but in fact, people who talk about it may attempt. Once a person decides to attempt suicide, there's nothing anyone can do to stop them. Well, we know that isn't true. Suicide is the most preventable kind of death, and almost any positive action may save a life. Those who contemplate suicide or make a plan, by and large, don't want to die. They just want their pain to end, and they can't see an end in sight or find a solution to their problems. So that hopelessness has set in, and that's where we come in as QPR gatekeepers, to restore that hope. All right. So suicide clues and warning signs, we talked about that a little bit. More clues and signs observed, of course, the greater the risk. We talk about warning signs and risk factors often. Warning signs are things you see. Risk factors are just more of facts about the person's background, or things that are going on in their lives or have happened in their recent past. But we take all signs seriously. They may give direct verbal cues. You know, like we talked about, I wish I were dead. I'm going to commit suicide. It's going to all end. If the threats of such and such happen, I'm going to kill myself. Other times there may be indirect verbal cues, like we talked about, a little more veiled. So who cares? I'm alone, right? I just want out. Won't be much longer. Another thing is behavioral clues. When you think of a behavioral clue, a behavior, what comes to mind? Maybe something that they've done. Giving away prized possessions. Researching. Maybe they've had a serious attempt. They're acquiring the means of their act, of their attempt. They may have a co-occurring of depression, anxiety, or substance use disorder. Oftentimes what happens with depression is that you begin to have a difficult time thinking and problem solving. The deeper the depression, the more constricted your thinking gets. And I was demonstrating to a gentleman the other night, and it's like, so here I can see, I can some peripheral vision. Then if I put my hands up, I can't see quite so well. And then as my depression worsens and my hopelessness gets worse and helplessness sets in until I just can't see a way forward. So maybe they're putting their personal affairs in order. Other behavioral clues we talked about, giving away prized possessions. A sudden interest or disinterest in religion, and use of drugs or alcohol, especially after a period of sobriety. Unexplained aggression, anger, and irritability. On the opposite side of that, anger and aggression, there could be a calm before the storm. So when that decision is made, often what happens is that person suddenly isn't crying anymore, isn't angry anymore, is just very calm and matter of fact in their interactions. Are there any questions so far? I know I'm going a little bit quickly. No? Okay. All right. So we talked about situational clues. Moving unwantedly. Maybe you've lost a home and you have to move into a little apartment. Losing a job, a loss of a relationship, the death of a loved one, especially by suicide. Once someone has lost someone close to them by suicide, they are at greater risk of attempting themselves. Having a terminal illness, especially among the older population. Loss of freedom, fear of punishment, incarceration, anticipated loss of financial security. I know it's a long time ago, but the Great Depression, the suicide rate spiked when the market crashed. Suicide rates also jumped 2007, 8, and 9. I don't have those specific numbers to comparison, but there was an increase. All right. Loss of a cherished therapist or counselor, if you've been very dependent on that person, and the fear of becoming a burden to others. So as we've gone through all of these things, the behavioral clues, the verbal clues, the situational clues, what we surmise is that, unfortunately, suicide is not a simple issue. It's a very complex issue. It's most generally never one thing that occurs that leads to a suicide crisis. In the news and media, often what happens when a famous person has died by suicide, you hear about one thing that was going on in their lives. And what that does is it influences people who may be on the cusp of a suicide crisis themselves. Well, they did it, and look at what they were going through. So, and then you have that effect of repeated suicides, or that contagion effect. So it's important to remember that suicide is never just one thing. Usually it's referred to as a stacking. I got a bad grade on a test. Missed that goal of the football game. I'm referring to youth, but my girlfriend broke up with me. My dad lost his job. Now we have to move. It's a stacking. And then the degrading of the behavior and grades, and nobody catches on. And the next thing you know, you have a crisis. Are there any questions about that? Okay, now let's talk about asking the question. QPR, let's talk about the question. One thing I want you to always keep in mind when you're asking the question, no matter how you say it, be direct, be calm, look people in the eye, comfortably, not a hard stare, because that can make people uncomfortable. Be mindful of what they may consider normal because of their ethnic background. There are some ethnicities, cultures that you don't lose eye contact, or staring, eye contact is considered rude. So always keep that in mind. Keep your body language in mind. Don't get all tense. Pay attention to the tone of your voice when you ask the question, and keep all judgment out. So if you're in doubt, if you see somebody who's been experiencing some things in their personal life that you know of, if you've noticed changes in their behavior, maybe in their appearance, they're missing work a lot, don't be afraid, don't wait. It's time to have the conversation and ask the question. If the person's reluctant, be persistent. Just continue the conversation gently as you can. Talk to the person alone in a private setting. Make sure that you have enough time to have the conversation. It can take a little bit of time, and you don't want to be rushed. Allow them to talk freely and give yourself plenty of time. Have your resources in hand. This is why I decided to do the little bag. Because usually we come in and we set up a table and we set out all the resources, and then people have to kind of thumb through them. So I just wanted everybody to have everything they needed when they leave here today. Okay? Know the resources in your community. It's so important. A less direct approach, say, have you been unhappy lately? Have you been very unhappy? Do you ever wish you could go to sleep and never wake up? Another thing about this less direct approach, and when you talk to somebody about suicide, you want to think about the words that you use and how you ask the question based on who you're talking to. It is very possible the person you're talking to doesn't understand the word suicide. English may be a second language. There could be a learning disability, and maybe they're a little bit younger. And they may answer you no, just because they don't know what you're talking about, okay? The direct approach, you can put this in your own words. Are you thinking about killing yourself? Are you planning on killing yourself? I've noticed you're very sad, and sometimes when people are that sad, they think about killing themselves. So what I would like to do now is just to stop for a moment and allow everyone to pair up and practice asking the questions. If you're here with a spouse and you would prefer not to do that with the spouse, you can go to someone else. Sometimes the spouse is more uncomfortable, sometimes it's more comfortable. What I would like you to do is to ask the question to your partner, wait for a moment, and then shake it off, don't answer back, and then let the other person ask, okay? Does that make sense? Okay, all right. And actually, I will come over here to you, sir. and go ahead and give it a try, and then we'll talk about that and what that was like.
You're going to do it with him?
Yes, yes.
Yes.
Hi, are you thinking about killing yourself?
No. Are you thinking about killing yourself?
Well, no. When you ask, it's important to keep all emotion, attitude, judgment out of the question. Because if you don't, the person may perceive that A, you don't really want that question answered. You don't want to hear yes. Or that you don't really take it serious. And they just be like, nah, whatever.
Most people in their lifetime think of doing it at least once.
Yes, those fleeting thoughts. And we're going to talk about, and we're going to talk about what to do when the answer is yes. What to ask next. Answering honestly to you is one thing. It depends on the child and how they perceive you. But I think that if I was the one asking the child the question or the young person the question, I would take my time and build up to it. And maybe start the question as, Mary, it's been a rough few months for you. I know that you have been through a lot, and we have a lot of work to do going forward. And I'm noticing when we talk that your eyes are cast down and you look very sad. And sometimes when people get that sad, they think about ending their lives. Have you been thinking about that lately?
But that's kind of what you described when you've been doing with the kids, is always ask about their medications, if they're taking them, or they supposed to.
Right. You may have a little bit more of a relationship at that point, and you know more about them, and they're more comfortable with you. That makes it easier. Okay? And if you get a little hem-hawing and you're still not making eye contact, and you know, one of the things I sometimes do with, not particularly in that situation, but when I'm talking to somebody who's struggling, is I'll kind of change the mood, the tone a little bit of what we're talking about, and maybe talk about something else for just a few moments, and then lead back up to that. Especially if we used to call them the spidey senses are going off. And,
What kind of senses?
Spidey senses, you know, that tingling that goes on, that you think, oh, something's not right here, and I'm not comfortable with that answer. As long as you can do it in a gentle way where you're not coming across as badgering. And if they're still not ready to talk, you can say, you know, can I call you in a couple of days, or when you come back, let's talk about this again. And then maybe you would express your concerns to their parents. Okay? And always make sure that you have resources on hand. You know, one of the things that we do talk about also is maybe you're just not comfortable talking about this with me. Who would you be comfortable talking to this about? Is there someone you can identify that you would be comfortable talking to? And if they can't, say, well, can I offer you this number, this text line?
Of course, if we learn to do something like cutting, they get an immediate referral.
Yes,
And if
yes.
they're already seeing a therapist, the therapist is talking to. I have all girls with long sleeve shirts on full of their sleeves.
Yes,
Every single girl.
good. Yeah.
What is the youngest person you have heard of that committed suicide?
The youngest that I know of is a 5-year-old, and I don't know any of the background information on that. And I only know this because I read a study recently that states that young African American children, particularly males, their suicide rates have gone up in the last few years, and the youngest was 5 years old.
How would they even know how to do it?
Yeah, I don't
I
know,
might have saw it.
saw something.
Somebody told them how, if
They could have seen a
know how the big
yeah.
brothers or sisters would
I-
say, well, if you want to do it, here's how to do it, or something.
Yeah, I couldn't bring myself to speculate much further than that because my mind did go to several different things that a 5-year-old could do. And the other thing is that, well, does this 5-year-old really understand the consequences? No,
Right,
of what they're
right.
doing.
No.
No.
Yeah, yeah. Okay. Any other questions or comments on that? All right, you guys did a great job. Thank you. All right. So let's talk a little bit about how not to ask the question, which we did. You know, you don't want to come across, you're not thinking of killing yourself, are you? Would you answer that question with a, well, yeah? Probably wouldn't answer that question, right? So you just want to stay calm, keep the judgment and the emotion out as much as you can, especially if it's someone close to you, so they know you really want them to answer you. You're not seeking a specific answer, okay? So persuading someone to get help. You've sat, you've listened, you've talked to them, they've said, yes, I am considering suicide. And before we go further, let me stop for a moment and back up. We were talking for a moment about the fact that, you know, many people have thought about killing themselves maybe once in their lives. Those fleeting thoughts happen. Most people get help and they're fine. But let's say that you're sitting with somebody, you've had the conversation, and you've asked the question, and they've said yes. There are some follow-up questions that you really should ask. Okay, so you're saying that you do want to die, you want to kill yourself. So do you have a plan? Yes. What's your plan? Okay, do you have what you need to carry out your plan? Get the information. And do you know when you're going to do this? Every yes, of course, increases the risk of death by suicide. So sometimes these follow-up questions bring you to a place where they say, no, I don't have a plan, I don't have what I need. I'm just so sad that I want to die. Of course, that's enough for intervention, but the more information that you have, the more information you can relay to emergency personnel, and the more serious of the crisis, okay? I had one gentleman in a seminar ask me one time, he said, well, what if one of my students comes in one morning and he says something like, oh, if I have to go to this class again, I'll kill myself. I'm like, okay, I'm sure you hear flippant, offhand comments from time to time. We all have. So have the conversation with him. You know, you might become his new best trusted teacher, and you may determine that he's really not suicidal at all. He's just really frustrated with his math teacher, right? So have the conversation. Don't be afraid to do that if you have any concerns. So you want to listen and give them your full attention. Suicide's not the problem. It's just the perceived solution to the hopelessness that they are feeling. And don't rush to judgment. Listen, active listen, take the time to understand what's happening with them, and offer hope in any form. I'm here for you. I'm your friend. I want you to live. I know you feel hopeless now, but I want to help you through this. Let me help you get some help. Then persuade them. Will you go with me? Let me help you get help. This last one, will you promise not to kill yourself until we found you some help? Well, when somebody is suicidal, don't leave them alone. That is not the time to leave them. If you feel you have to leave, tag team with somebody. If you can get someone else to sit with them until help arrives, do that. The other thing is you'll want to give them choices. Well, you can say to them, if they agree to get help, we have choices. We can, in Sanilac County, I'm going to speak in terms of Sanilac County, you can go to the emergency room. We can call a crisis line. We can text the crisis line, or we can call 911. Which would you like to do? Another option could be, if they don't want any of those things, is there someone that you trust that we can call who can escort you to the hospital or meet you there? When people have choices like that, they feel empowered and more comfortable to go forward. But what if they say no to all of those choices? That's when you have to kind of pull in the tough love and say, I'm sorry, but you've told me you want to kill yourself. And I care about you and I can't leave you alone like this. So if you won't go to the emergency room or call a crisis line, I'm going to have to call 911. And they might be really mad at you at that point. But that's okay. That's okay. Later, they won't be. Later, they'll be very, very grateful. Okay? And refer. So the best way is taking someone directly to where they can get help. Otherwise, a referral, a commitment to get help, that's another one of those things that I caution you about. QPR has an element of, if they don't want to get help, you could safety plan them. But that's getting more into the clinical side of things. And I also realize that QPR is taught all over the world. It's taught in countries where there's no crisis line, where the police aren't going to come, if somebody's suicidal. But that's not the case in Sanilac County. If you call 911 and say, my friend is suicidal, they are going to come, okay? So just never leave somebody alone who is actively suicidal, all right? So almost all efforts to persuade someone to live instead of attempt suicide will be met with agreement and relief, so don't hesitate to get involved. Another thing studies show is that about 50% of people will refuse to get involved in a perceived crisis just because they're afraid of making it worse. Well, all attempts to intercede are going to be met with acceptance and relief for the most part. So don't be afraid. Do you have any questions at this point? No. I thank you all again for coming out. Learning the warning signs and risk factors of suicide and how to help somebody who may be experiencing a crisis has been proven to lower the suicide rates in areas where there are a large number of trained individuals just like us who can help somebody who may be experiencing a crisis. So thank you. In your bags, there is a little booklet that says QPR, and it reviews all the information that I just went over this evening. And there's a card on the back that you can tear off and keep in your wallet. There's also a card that has all the information regarding suicide resources and counseling resources in our county, and a magnet that has the crisis hotlines on it. There's the National Crisis Hotline, Sanilac CMH Crisis Line, and the text line. They are all available 24/7 if you need help. Yes?
How long has Sanilac County had this in
The QPR program.
operation?
The QPR program, we just started just last year. Yes, yeah, I just finished my certification, I think, in the winter. Yeah. So,
Do we have a problem in Sanilac County?
yes, we do. You mean with death by suicide? Yes, we sure do.
Oh, I know we have a lot of problems, but I'm just talking suicide.
Yes, yes, we sure do.
Do
It
they
does.
relate that to drugs and alcohol? A lot.
So that is often a factor, but I couldn't tell you how often that is the main factor. And the problem with death by with alcohol and drugs is it's not always clear that it's a suicide. And if there isn't a note, it won't be attributed as a suicide. No. And then another problem that we have in Sanilac County with our numbers is that this is a wonderful hospital, but sometimes people have to be flown out to larger hospitals for further treatment. Also, if somebody who lives in Sanilac County happens to be in another county at the time of death, then wherever that person dies, that's where the suicide is attributed to that county, counted toward them. So what we get from our coroners is specifically if they passed in Sanilac County. Yeah.
Makes sense.
Yes.
Sad.
It is. I think there should be something added about the wrong drugs. I think our doctors are, there's stress, there's anxiety, there's depression.
Mm-hmm.
Those are all very, very different mental states. And I think our doctors are way too easy to give medication. Because if you're under a lot of stress and they give you medicine for depression, I mean, sometimes it'll just, I'm very, anxiety, that's a very different state of mind too. And I think doctors are just way too easy to just give you a pill, and if they don't know exactly what state of mind you are in, it can have the totally opposite effect.
You know, I understand where that perception comes from, but I feel like here in Sanilac County, knowing that like Mackenzie has the telehealth, and you're starting a new program soon, and community mental health also has their psychiatrist on staff, and Lakeshore Counseling has telepsychiatry as well, and I know that our psychiatrists work very closely with the primary care physicians to ensure that if somebody is stable enough to transfer from psychiatry to their primary care, that their mental health state is monitored and appropriate prescriptions are transferred over. So, you know, I can't totally speak to that.
The doctors have to be really careful.
Most definitely. Most definitely. I think that's true in just about any situation. Yeah.
In fact, it's such an issue now, it's part of the Medicare annual wellness exam. Depression screening and suicide risk screening is done annually, and it's also part of our emergency room screening for everyone.
Yes. Yes. In fact, Sanilac CMH worked with Mackenzie Hospital just a couple of years ago to develop a screening to help them identify. So, but I think that speaks more to maybe not catching what might be going on, but I think doctors are becoming more and more savvy about those screenings and asking the correct questions to determine if a referral to mental health needs to be made, right? Do you agree with that? Okay. Okay.
I think that's a good point, though.
Any
Yeah,
other
very.
questions for Kellie? I want to thank you very much.
Thank you. Thanks for coming.